This program is brought to you by Emory University.
Hi, good morning, everyone, and thank you for joining. Hope everybody had a nice April weekend. It's truly my great pleasure this morning to introduce our speaker who gets extra points because it is 4:30 in the morning there. So we really appreciate Dr. Jackie Shaw taking the time this morning. Dr. Shaw is a professor at University of British Columbia and interventional cardiologist at Vancouver General Hospital. She did her medical training at University of Ottawa in Ontario, and then internal medicine cardiology fellowship and chief year at University of British Columbia, followed by her interventional fellowship training at the Cleveland Clinic in Ohio. She's also the program director for the interventional fellowship training program. And she's really an international expert, and she's very well known for two areas, for SCAD and also for LA closure device with Watchman. She's very active in many professional organizations. I was telling her earlier that I was just super impressed with her CV, where she has over 270 publications and book chapters related to these areas. And today she's going to give us an update on SCAD. So I'll turn it over to you, Jackie.
Great. Thank you so much, Pooja. Thank you for having me. It's such a delight and privilege to be here this morning to speak to you on SCAD. And so without any delay, I'll just jump right into it. So SCAD, or spontaneous coronary artery dissection, is a really interesting condition that, I got interested in over 12 years ago now. And I think it's still fascinating, and we're still learning about this condition. And it still surprises me, some of the severity of the cases that we see. So this is the outline of my talk. I'm going to talk about the prevalence of diagnosis, the etiology, and the management and outcomes for SCAD. So this is a very first case report of SCAD back in 1931. This is a 42-year-old woman who, after eating a meal of fish and chips in a neighborhood store, had severe food poisoning. So she was retching and vomiting and retching and vomiting. And the next morning at 3 o'clock in the morning, she woke up, and then she retched one last time, and then basically fell back, and she died in her husband's arms. So this is really quite dramatic, like one of those Hollywood movies, And then when they did her postmortem anatomy, she was found to have marked atheroma that had apparently just ruptured during the last episode of retching and vomiting. So even though this has been used as the very first case report of SCAD, we now actually know that this really should not be the first SCAD report, because it was related to atheroma. So the modern day usage of the term SCAD really excludes atherosclerosis, because the treatment and the disease process is actually quite different for atherosclerotic form of dissection. So SCAD really is defined as a non-atherosclerotic spontaneous tear of the coronary artery wall that resulted in intramural hematoma in the false lumen, and that can occur without an intimal tear. So, this is the old standard classic textbook definition of what an angiogram of SCAD should look like, this multiple lumen appearance on the angiogram. But we've learned since the past decade that really, that's not the most common visualization on angiogram. In fact, the most common pathophysiology is the formation of intramural hematoma, and the appearance of that on the angiogram is quite different. So this is a case example showing a long diffuse narrowing, which is really subtle. And I would say before recognizing SCAD a decade ago, I probably would have missed this subtle finding. And in fact, we needed intracoronary imaging to diagnose SCAD in that case. And that really was what got me interested back in April 2011, when I saw 3 young women, as you see the ages here, 35 to 48-year-old women, who came in with non-STEMI. Many of these are when I was running a CCU or in a cath lab. And all 3 coronary angiograms, as you can see, are not typical appearance of SCAD. And we had just obtained OCT literally during that month at our hospital. And so we did OCT on all 3 patients, and lo and behold, each of these patients actually had intramural hematoma. So that's when I then recognized that, oh gosh, If I saw 3 women in 2 weeks, gosh, this condition is definitely not rare. We just didn't do a good job in recognizing it beforehand. So very early on in that experience, I looked at our hospital's angiogram, pull up all the angiogram of women who underwent angiography in my hospital, especially the young one less than age 50, and looked at how many of these cases that we missed. And in fact, we missed a lot of them. And in fact, when we found these women, when they had ACS, 24% of the causes of the MI is actually due to SCAD, and the vast majority of these cases we had missed. So why are we missing these cases? Well, for years, we've been doing angiogram without recognizing the more common pattern of this long diffuse narrowing. And also there's low clinical index of suspicion. Say a decade ago, when women present with chest pain, they are not very often even investigated. And we haven't been using intracoronary imaging in the early days as much. So what is the true prevalence of SCAD? Now, even though it's been reported in up to 4% of cases of coronary angiograms in patients presenting with ACS, I still think that is still an underestimate because we're still missing some of these more subtle cases. But when we look at series that comb through the angiograms very carefully for SCAD features, SCAD is a cause of MIs in women less than age 50 or less than age 60, similar to our series, accounts for up to a quarter to up to a third of cases. And if a patient has pregnancy-related MI, SCAD is a very important cause in up to 43% of cases. So clearly, it is not a rare diagnosis. So because of our challenges in diagnosing SCAD very early on in our experience, we tried to provide a simple classification that angiographers can use worldwide. So we came with this classification now, 8 years ago. So in terms of simplicity, so type 1, 2, 3, type 1 is the classic textbook appearance of multiple radiolucent lumen, which in this case, in the mid LED, you can see multiple lumen, and sometimes you can see staining of the contrast in the wall of the artery. And then the type 2s are the long diffuse narrowing. So in type 2A, you have a long diffuse narrowing that's bordered by normal vessel proximal to that and distal to that. And in type 2B is when the long diffuse narrowing extends all the way out to the distal part of the vessel, and that can mimic natural tapering of vessels. So you want to make sure you don't miss that. And then type 3 is the appearance of more focal to tubular stenosis that mimics atherosclerosis. And these are the cases where often you need intracoronary imaging to rule out atherosclerosis. So I'll show you a few case examples here. So this is type 1, so the classic one being this easy to recognize, but sometimes it can be quite subtle. And like this case here, and there's actually wall staining of the contrast, and you need to sit any longer to see that staining in the wall. And here's an example of extraluminal dyes hang up here as well in the obtuse marginal branch, and likewise over here. So a lot of times you need to sit long enough to see these extraluminal staining. These are examples of type 2A. So you have, this is the right coronary, whereas normal here proximally and normal in the PDA, but the rest of the RCA here is diffusely narrowed from intramural hematoma. And this is type 2B of the LAD, where from this point all the way down to the apical segment is occluded because of intramural hematoma. But you can see long diffuse narrowing before the occlusion. So this is type 2B. Type 3 is where you see stenosis that actually looks like cholesterol, right? So here in the distal RCA and the diagonal branch, and in both cases, intracoronary imaging shows intramural hematoma. And so I want to show you.
Sorry, I lost you for a second. Hello?
What's that?
I want to show more of the intracoronary imaging pictures, but just to show that, we have been using OCT a lot initially, but we do so less often now. And then nowadays, since we have high def IVUS, we tend to choose this if we are uncertain about the diagnosis of SCAD on angiogram. So let me show you what we found in the Canadian SCAD study. So of the 750 patients where we prospectively enrolled over the course of about 3-4 years, you can see we have about 1,000 dissected arteries that were adjudicated and assessed by now core lab by John Mancini's lab. And you can see the distribution of the angiographic patterns. So type 1 in 29%, and type 2 in 60%, and in type 3 in 11%, right? And in terms of intracoronary imaging, only 7.6% of patients require intracoronary imaging. And SCAD can affect any coronary vessels, but most commonly LED or branches in 52% of cases. And Pusha mentioned earlier she saw multi-vessel SCAD, and actually that's not that rare because non-contiguous, non-contiguous SCAD, so multi-vessel SCAD in different territories affects about 13% of cases, so it's not that infrequent. And very importantly, proximal vessel involvement is also is 8%. So the majority of SCAD cases affect mid to distal segments of the vessels. And also very importantly is to look for wall motion abnormality, because you almost always see that. So in 85% of cases, you see some degree of wall motion abnormalities of the segment that's subtended by the dissected artery. So if it's subtle on the angiogram of the coronary arteries being dissected, you want to look for the wall motion to help you, identify where the SCAD vessel is. I want to highlight that some of the Europeans actually use an additional category called type 4. We don't use it in Canada because usually they net type 4 as a total occlusion. And I've showed you in my other case earlier, even there's an occlusion, you can generally see the patterns prior to that occlusion in order to call it SCAD. Like if you have an abrupt occlusion with no long diffuse narrowing prior, you probably shouldn't call it SCAD because you won't be certain anyway. So in fact, in the cases in that example that it showed as type 4, we would have categorized as type 2B. And in the Canadian SCAD study, 30% of SCAD vessels were included. So, it would be unfortunate not to be able to categorize a third of cases, right? So we don't use that categorization. And we just find if you can't tell SCAD based upon total occlusion, you probably should not call it as SCAD anyways, right? Because it might be a thrombotic occlusion. So another important thing is the utilization of CAT scan to try and diagnose SCAD. I know, there's a lot of interventionalists who are thinking, well, because of the potential risk of angiogram for SCAD patients, can we just use CT scan? So some of the features on CAT scans are seeing also that long diffuse narrowing, and you might have mild edema and the surrounding perivascular fat. And sometimes you might see extra luminal contrast staining. But in fact, this is not very often seen. So how good are radiographers in terms of interpreting SCAD? So unfortunately, it's not that great. So there are two series I'll show you here, one from the Mayo Clinic, one from Spain. So you see in this first study, 18 SCAD lesions in 11 patients, and CTA only picked up 78% of cases. In the Mayo Clinic series, 16 vessels with SCAD in 14 patients, and yet only 2 cases were reported to be suspicious for SCAD. So you can see some of the features are very, very subtle. So, right. So, and also, SCAD affects mid to distal vessels in 90% of cases. So you end up missing SCAD if you use CT as a first line imaging. So we don't use it as first line imaging at this point, but if you're trying to look at, say, healing of vessels for SCAD vessels that was larger, then it might be useful in those scenarios, but not as first line diagnostic imaging. So this algorithm on how to diagnose SCAD, I think, still holds. We wrote this in a review article many years ago now. So if you have a patient where you're suspicious of SCAD, so typically this is a younger woman where she doesn't have standard cardiovascular risk factors, or she's had a history of FMD, for instance. You want to do early angiography when they present with an MI. If you see type 1 appearance, then you make the diagnosis of SCAD. If not, look for the long diffuse narrowing. And after you see it a few times, it becomes a pattern that's easy to recognize. In the past, we would do intracoronary imaging for type 2 or do repeat angiogram, but nowadays we don't need to do that. It's only the type 3 that we would do intracoronary imaging. So our current practice for doing intracoronary imaging is about 5% or less. So who gets SCAD? It is a condition that primarily affects women in 9 out of 10 cases. And the mean age of the series shows, of women age between 44 to 54. So these are the mean age. So when you look at a Canadian SCAD study, our mean age was 51.8, and you see the bell curve distribution of the ages, and ranging from 24 to 89, right? And so about 10% of patients were older than age 65. So I think that's important to highlight and note that, it's just because a woman came in and she's in her 60s or 70s, I don't necessarily exclude SCAD as a cause. It's just that when, women are older, when they present with SCAD, you end up seeing a bit more atherosclerotic disease in other vessels. But keep in mind, still, if they have disease greater than 50% of atherosclerosis elsewhere, we don't include them in our SCAD series. All right. And so you see, interestingly, amongst women with patients with SCAD, they tend to have other features like history of migraines, history of depression, and history of anxiety as well. So how do patients with SCAD present? They almost always present with an MI. 30% of cases, they have ST elevation MI. 70% of cases, they have non-ST elevation MI. In fact, it's very rare to have troponins being negative. And those cases were negative, usually because they presented late and those troponin levels normalize. And when you look for arrhythmias, we see in 8% of cases where they have sustained ventricular tachycardia or fibrillation during acute presentations. And injection fraction, the mean LVEF was 55%, and about a quarter has abnormal LV function when they present. And still, the most common symptom for presentation is chest pain in 91% of cases. So what causes SCAD? We're discussing this earlier and with Pooja. So, typically patients when they present with SCAD, they have an underlying abnormality in their coronary arteries that have weakened the arterial wall, right? So they have some degree of arteriopathy, and you see some of those potential causes here on the right-hand side. But a lot of times they then have an additional cardiocirculatory stress, so be it emotional or physical trigger that then triggered or precipitated the SCAD event in that perfect storm pattern, right? So you have weak arteries, and then you have severe emotional stress that then triggered the tear in the vessel. So I highlighted fibromuscular dysplasia here because this is one of the most dominant association with SCAD. So fibromuscular dysplasia is also a non-atherosclerotic, non-inflammatory disease of the coronary arterial wall that predominantly affects small to medium-sized arteries. And so in this condition, you have proliferation of small muscle cells, and then it leads to the angiographic pattern of these multifocal string of beads appearance in the renal arteries or iliac arteries. But in the coronary arteries, they can appear as ectasia or aneurysms or even just focal stenosis. But nevertheless, with FMD affecting these arterial wall, it weakens these arteries and also can cause dissections. So these are a number of case reports that have shown the histopathology that with cases where there's coronary FMD adjacent to those segments, you see hematoma from dissection, right? So these case reports basically shows the plausibility that coronary FMD can result in dissection. It's just that most of our FMD with SCAD patients survive, so we don't have a lot of autopsy reports on these patients. But biologically, yes, it can happen. Coronary FMD can cause SCAD. And so what is that link between FMD and SCAD? For many years we had thought, well, maybe it's due to the hormonal exposure in both conditions, because estrogen, progesterone, all of that can both cause FMD and can cause SCAD, and both disease conditions predominantly affects women. And then recently, a common gene was identified called the factor 1 gene, and with the A allele increasing the risk of SCAD by about 67% and increasing the risk of FMD by about 39%. So there is a common, at least one common, loci of genetic that can account for that. So that's an interesting finding recently. Now, in terms of trying to diagnose FMD in our SCAD population, we know that most angiographers, they prefer just to do a CT scan, or most clinicians do a CT scan because it's non-invasive. And in our early experience, we actually did a lot of non-selective angiography of our renal and iliac for our patients. And so we compare the sensitivity of doing CT to diagnose FMD versus angiography with non-selective catheters in an our cohort of patients. And we found that CTA was actually quite poorly sensitive. It was only 22% sensitive to look for FMD in SCAD patient population. And that's because a lot of times these FMD changes can be quite subtle, right? Where you can't really tell compared to what angiography is, because the resolution of angiography is down to 0.1, whereas on CT in the best of times is 0.5, and sometimes for non-coronary CTA people are using 1 millimeter cuts. So obviously the resolution is lower with CT, so you can miss these more subtle changes. So what we always recommend is that if you're doing the coronary angiogram of a patient in the cath lab and you found SCAD, I would just use a pigtail catheter and put it in the abdominal aorta, do a abdominal angiogram to see this, and also check out the iliacs to see these. And I would even go one step further. I would use digital subtraction to help improve our ability to pick it up. So this is DSA. So when we look at the Canadian SCAD study, and amongst patients who were fully screened, so meaning we recommend screening their head and neck, the renals, and the iliacs. So for those who are complete screen, we found FMD in about 56% of cases. Now, in this compared to our older series where we saw 86%, because most of that early series, patients had catheter angiography as opposed to CT. So in the Canadian SCAD study, we left it to the discretion of the operators to decide which one they would do. And then so if you compare that to other causes of SCAD, such as inflammatory disease, connective tissue disorders, and hormonal therapy, these are a lot less frequent. Okay, so I just want to point out connective tissue disease. For the genetic causes like Marfan syndrome, Loeys-Dietz, vascular EDS, for instance, even though they've been reported to cause SCAD, if you look at the overall frequency, these are very uncommon. So in fact, series where they routinely done genetic screening for a small cohort of patients, right? 44 patients, 59 patients in these two studies, they found genetically caused in about 5% of cases. So the yield for clinical genetic testing is low, so it's not recommended for all comers. Having said that, there's, this space is very active in terms of further research. There are a lot of collaborations between many different countries, actually, trying to get all the genetic samples together. So this is one of the series where we looked for novel genes that in SCAD patients, and SL4 is one of these novel genes that encodes extracellular matrix protein. And so in fact, when we did in situ hybridization, we detected this SL4 in the arterial medium of human coronary arteries. So, so these are some of the novel genes that can be associated with SCAD. So stay tuned for more results. There's GWAS collaborations going on in this space. So what about inflammatory disease? Older series, we've reported, perhaps 5 to 12% of SCAD patients having some, inflammatory disease. But when you look at series that looked at inflammatory markers that were measured, those were not higher amongst patients presenting with SCAD. And so when and this study was a case control study published in the Mayo Clinic group, and I think that's important. They compared 114 patients with SCAD from Minnesota and Wisconsin and matched them to 342 controls. And then they looked at the incidence of inflammatory disease. So it listed, all the conditions are listed on the right-hand side, like Crohn's and, ankylosing spondylitis, etc. But you see that the incidence of autoimmune disease among SCAD and non-SCAD cohorts were actually not different. So likely these inflammatory conditions were just bystanders for patients with SCAD. Now, what about hormonal therapy? 10% of our cohort actually were on some degree of active hormonal therapy, be it birth control pills or on HRT. And so if you look at, these agents, so estrogen can increase matrix metalloproteinase, can cause cystic progesterone can impair collagen synthesis, right, and affects the integrity of elastin. elastic fibrin. And so these in the long haul, with long exposure or recurrent pregnancies or multiple pregnancies can weaken the coronary arterial wall and cause SCAD. And then there's a cohort of patients with peripartum SCAD, right? And the old literature has suggested peripartum being a very important cause, but if you look at contemporary series, peripartum SCAD really accounts for 5% or less of SCAD. All right. And so importantly, are these precipitating stressors. Early on, we identify a lot of our patients have very, very intense emotional stress, like death in the family or loss of job or marriage breakdown that triggered their event, I'd say within a week. So our patients in our series, we have them complete a questionnaire. So they'll fill out and say, well, within the past week, what is your level of stress? And they rate out of 4. So rating high or severe was 50% of our patients. And about 30% identified also intense physical stress. In total, 10% had intense isometric stress, the lifting weights of more than 50 pounds. And only about a third of patients, there's no precipitating factor. We then subsequently also look and compare men and women with SCAD because their precipitating stressors are quite different. So men in blue and then women in red, you can see the bars. So emotional triggers is a lot more common for women presenting with SCAD, but less physical trigger in women. And also men with SCAD, a lower incidence of FMD, which is about 30% compared to about 60%. But I just want to, again, mention that because FMD predominantly affects women in the first place. 9 out of 10 cases affect women. And so it's rare, first of all, to have men with FMD, but yet in the Canadian SCAD series, 30% of men have FMD. So this is a lot higher than on the general population. So in fact, I always say when men have SCAD, number one is uncommon, but when they do have SCAD, a lot of them, almost half of them basically have FMD as an underlying cause. And then the rest of them actually have very intense, usually physical triggers that have caused that. Importantly, the cardiovascular outcomes for the objective endpoints are not different, but women were more likely to be readmitted for chest pains So how do we manage SCAD? And so I'm just looking away because my puppy keeps walking around, so I was just make sure that she's not up to no good. And so in terms of management for SCAD, we can divide it into acute management in hospital and a long-term management, and so trying to identify some of these predisposing causes and also trying to prevent recurrent SCAD. So management in hospital really depends on how aggressive their presentations are. And most patients actually, by the time they present to us in the cath lab, they've stabilized. They don't have further chest pains. They've only had a small MI, so we can treat them conservatively as recommended by the AHA and the ESC consensus statements. But there's a small proportion of patients in about 8% of cases where they're high risk presentations. So they have ongoing ischemia, ongoing chest pain, or they're hemodynamically unstable, right? Or they have left main dissection. And these cases, warrants more aggressive management. So these are the ones that we would need to revascularize. But the vast majority of other patients, they can be treated conservatively because we know that the natural history of these tears are that they would heal spontaneously over time. So we and others have looked at repeat angiograms in these patients who are managed conservatively. So we have one of the largest series where we had 156 patients who were conservatively managed and subsequently had repeat angiograms for whatever reasons. And so if you repeat the angiogram at least 30 days after, we see that 95% of these dissected arteries have healed. So that's important to know, which is why, in most cases when the patients are stable, we don't intervene. So having that knowledge, early on when we were trying to boost or, enroll, recruit sites for the Canadian SCAD study that travel across the country to give lots of SCAD talks and strongly advise conservatively managing these population of patients. So in fact, when you look at the Canadian SCAD study, conservative management was done first line in 86% of our patient cohort. And of these conservatively managed patients, subsequently 2.3% required revascularization. So that's a pretty low incidence. So then in total, 84.3% of the 750 patient cohort were treated conservatively overall for their presentation. And you see only 15% required revascularization. And of that, the majority, 14%, were treated with PCI, right? So that's contemporary practice, 22 sites throughout North America. Of these, 20 centers were in Canada. And so if you look at the cohort of patients who underwent PCI, so 106 patients, 14% of cases, what are the outcomes? Roughly 30% were unsuccessful, okay? And Stefan would tell you that, that's pretty low incidence of success rate compared to even CTO intervention. And that's because, intervention for SCAD it can be quite challenging because, you can extend the dissection, etc. So if you look at the strategies that we use in this 100 patients or so, stent placement was used in the majority of cases, 65%, and about 20% have balloon angioplasty. And then that was the era where we were just starting to use cutting balloons as well. So we had a few experience with cutting balloons in that series. So what are some of these challenges then with intervention for SCAD? One of the most important one is causing iatrogenic catheter-induced dissection, which can be really unfortunate for our patients. And so this is an example of a dissection of a patient who had a dissection on the left side, but now dissected the right coronary from an AL1 diagnostic catheter. And this is an example of a guide catheter causing left main dissection in this patient who ended up requiring bypass surgery. And this was a case of just, again, a patient with LAD dissection. This is the first shot. And then the second shot, boom, the catheter caused dissection. There's a diagnostic, GL 3.5 catheter that caused left main dissection. This patient just did poorly, needed surgery. And then there are other issues, propagating the intramural hematoma with angioplasty or stenting, or having really extensive dissection, you need long stents, and then you end up having in-stent restenosis subsequently, or even stent malapposition after resorption of the hematoma causing late stent thrombosis. So these are realities about intervening. But we want to make sure that the pendulum doesn't swing completely the other side and then people don't do intervention for high-risk cases. So that shouldn't be the case either. So I think when there's a right indication to do PCI, you should do it. And these indications would be usually left main dissection, or the patient's in shock, or they have ongoing ischemia, ongoing ST elevation. So these cases, we would definitely intervene if we can. And this is an algorithm just to kind of, give you an idea about how we should manage these. Normally, if it's left main, most patients would end up requiring bypass surgery. For non-left main, we want to make sure that we wire to the true lumen, and then you go according to the angiographic subtype. If you have a short enough lesion that are type 3 for sure, or even some type 1s, and you can cover with a single stent by making sure you can extend the stent coverage by at least 5 millimeters on both edges, then that probably is the best way to do it. But if you have really long dissection, then in those cases, we favor using cutting balloons. So I'll show you a couple examples here. So this is a type 1 dissection in the mid-LAD, where you got to be careful wiring the true lumen. In this case, was successful getting the true lumen. A long stent was placed. You can see it covers by more than 5 millimeters on either side, right? So you can see long stent, and this is the final results. That looks good. And the reason to do long stent is to try to make sure that you tack up the intramural hematoma on both sides to prevent propagation of the hematoma. So this is a type 2A dissection that I did with Simon Walsh many moons ago when he was training under us. And so here we stented distal, and then we stented proximal, and then we stented the middle. And so this is the final results. The results look great, but this patient ended up having 3 long stents. I would say nowadays I would just use cutting balloon and perhaps even avoid stents altogether. So this is an example where we use cutting balloons. So this is a diagonal dissection in a patient with ongoing lateral ST elevation MI. You may not think very much of this diagonal branch at that time, but after wiring and doing a few cutting balloons, inflation, we see this big diagonal artery actually, and basically achieve TIMI 3 flow. Even though there's still some dissection, the flow was normal and the pain resolved. So we actually didn't need to put stents, which I'm happy with because this vessel was quite tortuous. So we didn't really want to put stents. We didn't need to do it. So what about bypass surgery? So, we really relegate CABG to patients where we can't intervene with PCI or those with left main dissection that are extensive and affects both the bifurcation into the LAD and circumflex. So in those cases, I think bypass surgery would be better compared to PCI in many cases, because then you're not exposing your patient to multiple stents. And very important to note that the CABG, the bypass surgery, is really done to make sure that the patient survive the acute event, right? We're not trying to do this for long-term graft patency, right? In fact, the small series have shown that in dissected arteries, when you graft them, over half of these bypass grafts close down very early on because, these dissected arteries heal. And so, but the key is that you want to improve the acute survival of these patients and improve the coronary perfusion very acutely for these patients where you have no option with PCI or the PCI has failed. And so the recommendation is, you can use your vein grafts. It saves you time than trying to pull your internal memories. And so really think about acute survival. Fortunately, in our series, only 0.7% underwent bypass surgery. So this is, is unfortunately to require that, but it's very low frequency who needs that. So what about medical management long-term? So we generally do advise aspirin and beta blocker long-term for our patients. Beta blockers reduces the DPDT, potentially reduces the risk of recurrent SCAD. In our older series, we found that the use of beta blocker was associated with reduction in a recurrent SCAD by 60%. And so it was recommend optimal hypertension management. And all the other medications are highly controversial. So do you use clopidogrel for all comers with SCAD, even though they haven't had PCI? Well, some operators don't feel strongly. In fact, there hopefully will be a global consortium to try and randomize patients with SCAD to DAPT versus single antiplatelet therapy. So, we'll have to find funding for that. And also, ACE inhibitors, we only utilize that for patients where there's wall motion abnormality, and statins only if patients have underlying dyslipidemia according to standard guidelines. And we generally don't continue patients on nitrates or CCB long-term. So this is, I would say, the first randomized trial that's currently ongoing called a BA SCAD, where patients were randomized in the 2x2 factorial design, beta blocker versus not, and DAP versus SEP. From Canada, we're also trying to, fingers crossed, if we get funding to do the battle SCAD study, comparing that as well. Other strategies to prevent recurrent SCAD, not just beta blockers and management of hypertension, but also really try and target their emotional stress and eliminate, physical stress, physical triggers if you can. So we tell our patients, right, a lot of them have these emotional triggers. He said, we provide them with psychosocial support. We say, you really try and not, try to really not have very, very intense emotion that can potentially trigger SCAD. And also in terms of physical activities, we recommend our patients, men not lift anything more than 50 pounds and women not lift anything more than 30 pounds. I mean, these numbers are empiric, but we've seen cases where women had SCAD trigger from lifting a heavy suitcases or lifting a stray dog from the street that triggered SCAD after they've had an initial event. So these are some of the recommendations why we ask them not to be involved in lifting heavy weights, because they can be valsalvating and increasing the intra-abdominal pressure that can trigger SCAD. And also we tell them to avoid competitive sports. So, I mean, if you normally running 5K or 10K, fine, you can go back to that, but you probably don't want to do a marathon because there's a lot of anxiety and sympathetic stress when you're doing a race that we advise our patients not to do. Now, we also tell them to avoid long-term hormonal therapies and avoid basically estrogen and progesterone, and avoid future pregnancy as well. So what are the outcomes we see with that kind of holistic approach for managing SCAD patients? So what are the outcomes that we then see? So in the Canadian SCAD study, if you look at the in-hospital events, overall MACE 8.8%. This included recurrent MI in hospital for about 4% of cases. And fortunately, mortality is very low, 0.1%. and even out to 30 days. So this is overall 30-day MACE, which includes death, recurrent MI, unplanned revasc, stroke, TI, heart failure was 8.8%. And predictors of 30-day MACE were pericardium SCAD and connective tissue disorders, which makes a lot of sense, right? And then when we follow these patients out to 3 years, and we published this 3-year data in JACC a few months ago, and if you look at the overall 3-year MACE, 14%, mortality is 0.8%. It's actually not too bad. Recurrent MI in 10% of cases. And if we look at the distribution of these causes of recurrent MI, 21% of cases, or in total, the numbers 2.4% over 3 years was due to new de novo recurrent SCAD. Whereas early on, you have extension of SCAD in 3.5% of cases. So that's the acute SCAD vessel that have propagated in their acute event. So that's 3.5%. But after that vessel heals, subsequent new recurrent de novo SCAD is 2.4%. Look at the incidence of iatrogenic dissection, 1.9%. So this is not rare. So you got to be very careful when you do angiography of these SCAD patients. And in other cases, a quarter, because not all patients have repeat angiogram after the initial SCAD event to see what the causes are. So if you look at the Kaplan-Meier curve, overall MACE 14%, majority of these, more than half happened within the first 2 weeks. And then de novo SCAD, you can see it's a slow increase over time. So, this incidence is a lot lower than what we had suggested from older retrospective series. Because in our old series, we said maybe your recurrent SCAD risk is 3 to 5% per year. And but we're seeing it now. This is a lot lower. Now, is it because of our modern contemporary practice of management with medications? I think this accounts for some parts of that. So if you look at medications at discharge, 94% of us who are patients with discharge on aspirin, 85% discharge on a beta blocker, and 67% discharge on a DAPT. So this is usually clopidogrel. And at follow-up at 3 years, so 80% remains on aspirin and 73.5% remains on a beta blocker. So we have a very high utilization of beta blocker and aspirin. So that might account for that low recurrent SCAD rate. And also importantly, is the persistence of chest pains after a SCAD event. Okay, so at 1 month, we still have 50% of patients having recurrent chest pain. Majority, have atypical pain, but you have 10% of those 50% with typical angina. And at 3 years, still 1/3 still has persistent chest pain, and still a majority with atypical chest pain. So this is a very common phenomenon. Post-SCAD recurrent chest pains are very common. So this is also another important data from the CAN-SCAD study, which is what happens to the patients after a PCI in a SCAD cohort. So I mentioned 106 at PCI. And if you look at in hospital events, obviously the PCI cohort is going to have higher risk because they were chosen to have PCI because of their high risk features on angiogram. But when you look at after discharge from hospital, what are their outcomes? Is actually not different compared to the cohort who did not receive PCI. So I think this should be reassuring data that if a patient needs PCI in the hospital, do it. The long-term outcomes are not any worse than the non-PCI cohort. And so in terms of multivariable predictors for worse outcomes at 3 years, it was the presence of genetic disorders as listed here, and also postpartum patients, basically within 12 months of delivery, and also extracoronary FMD. So we identified the presence of FMD increases the hazards of recurrent SCAD, so of the MACE, overall MACE events out to 3 years. I do want to highlight, the challenging management of patients with postpartum or peripartum SCAD. Even though these are infrequent, so less than 5% of cases of SCAD, they tend to present worse. So they have worse in hospital major adverse events and worse high-risk features. And in fact, a lot of these postpartum patients end up requiring revascularization. So conservative management may not be adequate for these patients because they tend to have the left main dissection or multi-vessel and proximal vessel SCAD. So do keep in mind that, if I see a postpartum patient with SCAD, I tend to keep them in hospital longer and have low threshold to manage them with intervention. So because chest pains are so common after SCAD, it's important to try and delineate what is the cause of these pains. And so these are, some of the explanations of why a SCAD patient can have pain post. It can be extension of SCAD. It can be due to new recurrent de novo SCAD, right? It can be due to ACS non-SCAD. But the vast majority of them actually have atypical non-exertional pain, and it's not even ischemic pain. So the algorithm here from the AHA scientific statement, I think is a good algorithm, is to try and delineate. You do imaging, or you do stress imaging or stress tests to identify is it ischemic or not. And if it's non-ACS, non-ischemic, then we tend to treat them, medically and reassure them. If there's any abnormalities on the stress testing, then we might do a, either CT scan or repeat angiogram to evaluate that. If they come in with an ACS with TROP positive, then we will do a repeat angiogram for those folks. And the other management scheme includes recommending rehab programs. We're fortunate that we had some funding from philanthropy to do a SCAD specific rehab program. We've done this for many years now. And so our early series have shown that for having SCAD patients go through a SCAD rehab program, they do better. They have improved symptoms. They have improved, depression score. They have better outcomes in the long term. They're lower chest pain. So it's not higher risk, but it's recommended for them to undergo rehab program. And one of what we want to try and explain why SCAD patients have chest pains post. So in one of our studies, we measured the microvascular function. This is a small cohort of patients. We enrolled 18 patients where we did routine microvascular testing in these patients with persistent lifestyle debilitating chest pain post-SCAD. And we found that more than 70% had coronary microvascular dysfunction in our SCAD patients. So this may be an explanation for why SCAD patients had persistent chest pain post-SCAD. So I'll summarize here that SCAD is not rare. I think the prevalence is a lot higher than what is posted in literature now. So you need to be very vigilant of looking for SCAD in young to middle-aged women presenting with an MI. And you need to be familiar with the different types of angiographic patterns. And nowadays we reserve intracoronary imaging for unclear cases, so that accounts for less than 5% of cases. And so still most patients will be treated conservatively because they settled down. But if there are high-risk features, the interventional colleagues will have to manage them in the cath lab. And if we have all these strategies in place, and we see that the long-term outcome in the SCAD cohort of patients is actually pretty good. And we do need to screen these patients because there's prognostic indications, right? Patients with FMD tend to do a bit worse than non-FMD patients. We should screen for that and be very mindful about other strategies that patients can do to prevent recurrent SCAD, so that managing the emotional and the physical triggers. So I'll take the opportunity to thank all our collaborators from across Canada and also a couple of centers in the States. We've expanded our cohort of patients to 3,000. We're trying to enroll 3,000 patients. And also we're still, enrolling patients in our genetics cohort of patients to get to 1,000 genetics studies as well. So these are all collaborators. And if you want to learn more about SCAD, we have the Vancouver SCAD conference that's in May 6th and 7th. Olga will be attending on faculty. And we also have the Vancouver SCAD run that's every year. If you want to join us, the 5K run walk, you can register on vanscad.ca. And thank you. So join us if you can. Happy to take questions.
As expected, that was outstanding. Thank you so much. That was a really nice update. I'm going to open it up for questions. So go ahead and type your questions in the chat or raise your hand. And while we're waiting, I'll go ahead and ask a question. So you mentioned underlying sort of arteriopathy as one of the things, like there's something in the arterial wall and then plus there's a trigger. So two hits. And I'm just wondering for people who don't, so SCAD plus FMD, that association is probably about 60% of SCAD. Seems like there's FMD. So what about the non-FMD? What kind of arteriopathy are we talking about?
Yeah, so I mean, a lot of times, we screen and we don't see FMD. So there is still that idiopathic cohort, but I think just because we're not either not screening them properly, they're not getting the full, non-selective pigtail injections to screen for FMD, or some other conditions there are. So these are very often the patients with vascular EDS or Marfan's, but that still accounts for less than 5% of that cohort, or their postpartum, and or some other novel genetics that we haven't identified. So I highly encourage all our patients to be a part of the genetic study, because there are novel genes that we discovered that actually increases risk of SCAD. So these idiopathic causes, I think, have some underlying novel genetic markers that are promoting that. And then I think in men, so that applies to a lot of women. In men, it's quite interesting because, we screen for, I would highly encourage all men to be a part of the genetic study for sure. And then for men, we see, as I said, 30% have FMD, right? And then the rest of them have done such intense activities, right? So I have like men who are trying to lift an armoire by himself, right? Really, really heavy furniture that's over 100 pounds, or trying to, lift a tree trunk off the ground. Things like that really triggers. And I think that very, very intense physical stress can trigger, perhaps without even any, arteriopathy to begin with. So that's why I think we need to be, tell patients to avoid that as a recurrent trigger.
Yeah, it's very interesting how intense sort of emotional or physical stress, in some people it ends up being a Takotsubo type presentation, and in some people it's SCAD,
Right.
especially for women.
That's just-
Brian Wells has a question.
Hey, Dr. Saw, thanks so much for your talk. This is Brian. I'm the PI for the SCAD study here at Emory. And I had two questions if you have time. One is a question Dr. Mehta and I have discussed before, and you've had an abstract on that we've looked at, is coronary flow reserve in SCAD patients, either by PET or invasive. What are your thoughts about coronary flow reserve in terms of microvascular disease, particularly in these patients who have chronic chest pain, and how you manage it or approach that? And then the second shorter question is, are there data in SCAD patients with for cardiac rehab specific to this patient population? Thanks so much.
Yeah, thank you, Brian. These are important questions. And so I think microvascular dysfunction, I think, is an important cause of the chest pains. And I think it probably underlines some of the causes for these patients that have SCAD in the first place. So I think coronary FMD affects vessels, small to medium size, but it can be really small vessels as well. So, I think some of these, as we see 70% of our serious patients, or 18% that we did testing for, and we found 70% with coronary vascular dysfunction, microvascular dysfunction. I think, either it's underlying coronary FMD, or from maybe the acute dissection, or from microembolization following the SCAD event. So I think a lot of these persistent pain can be related to that. So I think it'd be great. We have a larger series. I'm happy to collaborate and see if we can test more patients. That will be ideal so we can highlight how do we manage these patients. And at this point, we intensify the beta blockers. We may add CCB, or we may consider ranolazine for these patients post. And we don't know if that would improve their symptoms long term. But I think generally for patients with very debilitating symptoms, we usually, because a lot of them have in our older series where we either repeat angiograms or done CT and follow, or et cetera. And so we're able to reassure them and say, well, there's nothing in the epicardial, so your prognosis probably, is not too bad. So we try and reassure them, and we try to encourage them to undergo cardiac rehabilitation. And I think having that cohort of patients where everyone have SCAD, you have someone to talk to, you don't feel isolated with that condition, I think is very, it has a lot of, healing aspects to that. And so our patients really appreciate having, being a part of the rehab program. So we highly encourage them to join the rehab program post.
Do you think that patients with SCAD, their event, which brings them to the hospital with a chest pain, and then they get diagnosed, but has anybody looked to see whether they were having off and on intermittent chest pain type symptoms even before, a few months or years before, and maybe they just didn't, think about going to see a doctor until it became really intense, and then they hit your ER?
No, that's a good point. So yeah, a lot of our patients have described they've had, funny pain or atypical pain for many years before coming in. But we haven't routinely collected that information. I won't be surprised to see like an important proportion of patients actually did have funny symptoms even ahead of time. So to explain why, they're probably the ones who have microvascular dysfunction to begin with, right?
Yeah, I was wondering if they had some kind of endothelial, microvascular reactivity types symptoms even before, and then
right, yeah. As you know, we don't, routinely a lot of doing microvascular testing is still so very infrequently performed, so we don't have that quarter patient. But it's interesting that some of our patients with SCAD actually had pre-existing FMD diagnosis, and so we know that the FMD in the past and did not present with an MI. We are very much looking for SCAD on angiogram for that cohort of patients, and we have seen SCAD in a number of these patients with FMD. So that's interesting. So.
Mm-hmm. Well, it's right around 8:30. I'm so sorry. It's so early for you. I hope you get a chance to go back to bed for a little bit. We really, really appreciate your time this morning. And, I look forward to seeing you in person at the next ACC or AHA.
Wonderful. Well, thank you so much for having me, appreciate.
Great. Thank you everyone for joining, and don't forget to get your CME credit, and I'll see you next week.
The preceding program is copyrighted by Emory University.